I'm often asked about the management of melanoma, and what I'd like to address today is 6 short topics. The first is the importance of the team approach. The second is the management of surgical margins. The third thing I would like to talk about is the assessment of metastatic spread. The fourth thing is the use of sentinel nodes, sentinel node biopsy. And the fifth thing is the long-term follow-up. I would also then like to address the role of modern immunotherapy. Regarding the team approach, the general practitioner and the skin clinic are probably the most important in terms of diagnosis. The surgeon then becomes important, but the most important member of the team is the pathologist. Later, the medical oncologist, the radiologist, and even a plastic and reconstruction surgeon are important. The pathology is very important. Most melanomas are in situ or lentigo maligna, the Hutchinson's melanotic freckle. The other common ones are superficial spreading melanoma and nodular melanoma. There are less common ones, including amelanotic melanoma and also the acral lentiginous melanoma. The important thing about the pathologist's contribution is that the pathologist gives us the diagnosis, the Breslow depth, and also then tells us about the mitotic rate and the presence or absence of ulceration. With regard to margins, the evidence is patchy. Over my career, margins have diminished enormously, but what we have agreed on now is best practice. With melanoma in situ, the required margin should be 5 millimetres. With a melanoma less than 1 millimetre in depth, it should be 10 millimetres. And with a melanoma of 2 millimetres in depth, it should be 20 millimetres. But essentially, the research is inconsistent. What we all agree upon is that the excision should be enough to excise all the melanoma and any evidence of cells in the subdermal lymphatics. Essentially, it is a belt and braces approach. Excision of the lesion for diagnosis, and then a wide and deep local excision for treatment. With regard to the assessment of spread, there is no investigation recommended for routine use. There are investigations that are useful when metastatic disease is suspected. A CT scan, which is easy to obtain, MRI, which is very useful looking for brain metastases, and probably the most advanced scan that we have now and very useful for melanoma is the PET scan. There are no blood tests that are useful at all in the detection of metastatic disease. There are, however, blood tests that are quite useful in the management of advanced disease. The sentinel node was the great hope for surgeons in advancing the management of melanoma. Donald Morton identified the sentinel node and sentinel node studies in 1992, and over the next 20 years there have been numerous studies trying to find a benefit for a surgical approach to the cure of melanoma. The melanoma sentinel node trial 1 proved that it was feasible, but all it concluded was that a negative sentinel node offered a good prognostic indicator. A positive sentinel node was not so good. The second trial was designed to find out whether removal of all the glands in a lymph node drainage point were actually advantageous after identifying the sentinel node as positive. This was the great hope for surgery, but unfortunately, over time we have discovered that there was an improvement in the nodal basin clearance, but there was no survival advantage after sentinel node biopsy. Sentinel node biopsy offers only prognostic information. A negative sentinel node confers a much better prognosis, a positive sentinel node a worse prognosis. It is the most significant prognostic tool that we have. It is difficult to know who and for how long a patient with melanoma should be followed up. The evidence is again patchy, but what we do know is that most melanomas that recur will recur in the first 12 months. 47% in fact recur in the first 12 months. Another 30% recur in the second year. So within 3 years, at least 80% of melanomas that recur will have recurred. However, melanoma can recur as long as 10 and 15 years after initial excision. Consensus would suggest that follow-up for melanoma should run on for at least 2 years and possibly more. It can be done by any clinician who has an interest and wants to become involved. Essentially, it becomes a matter of looking for evidence of new primary disease and evidence of recurrence of the initial primary. That can be done by anybody with an interest, but it can be done a little bit better by a clinician trained in dermoscopy. Consensus suggests that follow-up can be done by any interested and committed clinician every 6 months over at least 2 years. This should include an annual skin check and probably just education as to what the patient should be looking for. 75% of patients find their own recurrence when it does occur, even though the evidence would suggest that patients are poor at finding new disease. Immunotherapy is the latest addition to our armamentarium. It is, in fact, the biggest advance we have had in the management of melanoma over my career. It is at the moment being used for advanced disease only, that is stage 3, node positive, or stage 4, metastatic disease. It's a fascinating new form of therapy which has been developed after years of investigation into a cure for HIV. It actually concentrates on the T cell. The T cell contains immune blockers. These are called checkpoint blockers or checkpoint inhibitors. The checkpoint inhibitors actually decrease the effectiveness of the immune system. They directly affect the T cell. These new drugs are checkpoint blockers that inhibit the checkpoints and allow the T cell to perform at its maximum ability. The drugs that you know are nivolumab, ipilimumab, pembrolizumab. The ipilimumab is a CDTA blocker. The pembrolizumab and the nivolumab are both PD-1 blockers. These two in combination are very important in the modern management of metastatic melanoma. There are other blockers as well, but these are actually gene therapy blockers. These are the BRAF blockers and the MEK blockers. They are used for proven BRAF mutated melanoma. The results are astounding. 50% of people with metastatic melanoma respond to these drugs. 30% of people, in fact, have lost all evidence of disease and are surviving for more than 5 years. This is the greatest advance we've seen in the management of melanoma over my career. In summary, there have been major advances in the management of melanoma, unfortunately not so much in the surgical management. However, we do have to remember that surgical management is the prime treatment for the majority of melanomas. Surgery cures the vast majority. But it is in the area of metastatic spread that immunotherapy is coming to the fore and will change the management of melanoma over the next 10 years.